So next we'll discuss about the nausea. Up to 70% of patients with advanced cancer have nausea, defined as subjective sensation of wanting to vomit. Nausea and vomiting are both caused by stimulation at one of the four sites. One is GIT, vestibular system, chemoreceptor trigger zone, and cerebral cortex. GIT, vestibular system, chemoreceptor trigger zone, and cerebral cortex. Medical treatment for nausea are aimed at receptors of each of these sites. GIT contains mechanoreceptors, chemoreceptors, and 5-HT3 receptors. And vestibular system contains histamine and acetylcholine receptors. And chemo trigger zone contains dopamine type 2 receptors and 5-HT3 receptors. An example of nausea that is most likely is mediated by cortex is anticipatory nausea before a dose of chemotherapy or other noxious stimuli. Specific causes of nausea include metabolic changes, liver failure, uremia from renal failure, hypercalcemia, bowel obstruction, constipation, infection, GERD, vestibular disease, brain metastasis. Medications include antibiotics, NSAIDs, proton pump inhibitor, opioids, and chemotherapy and radiation therapy. Anxiety can also contribute to nausea. Medical treatment of nausea is directed at anatomic and receptor mediated cause revealed by the careful history and physical examination. When no specific cause of nausea is identified, many advocate beginning of the metoclopramide. Metoclopramide is serotonin type 3 receptor antagonist like ondansetron and granisetron, palinosetron, dolasetron, and propionsetron or ramosetron. Dopamine antagonists such as chlorpromazine, haloperidol, and chlorpromazine. When decreased motility is suspected, metoclopramide can be an effective treatment. When inflammation of the GIT tract is suspected, glucocorticoids such as dexamethasone are appropriate treatment. For nausea that follows chemotherapy and radiation therapy, one of the 5-HT3 receptor antagonists or neurokinin 1 antagonist such as eprapitate or fosapretate is recommended. Clinicians should attempt prevention of the post-chemotherapy nausea rather than simply providing treatment after the fact. Current clinical guidelines recommendation that tailoring the strength of the treatments to a specific emetic risk posed by the specific chemotherapy drugs. When a vestibular cause such as motion sickness or labyrinthitis is suspected, antihistamines such as meclizine, whose primary side effect is drowsiness, or anticholinergics such as chlorpromazine can be effective. In anticipatory nausea, patient can benefit from non-pharmacological interventions such as biofeedback and hypnosis. The most common pharmacological intervention for anticipatory nausea is benzodiazepines such as lorazepam. As with histamines, drowsiness and confusion are main side effects. The use of medical marijuana or oral cannabinoids for palliative therapy for nausea is controversial. A meta-analysis showed that cannabinoids are associated with improvement in nausea and vomiting due to chemotherapy, such as treatment are not as good as 5-HT3 receptor antagonist, and sometimes can even cause cannabis hyperemesis syndrome. Older patients, the vast majority of the dying patients, seem to tolerate cannabinoids poorly.